We're discussing your recent study looking at CD14 positive monocytes in rheumatoid arthritis. What do your findings mean for individuals at risk, the people who don't actually have any clinical signs of rheumatoid arthritis at the moment?
So I suppose at this point, we'd shown that these circulating RA monocytes were poised to produce these pro-inflammatory mediators. They had this hypermetabolic phenotype with what seems to be a reliance on glycolytic mechanisms, and also that this may be potentially regulated by STAT3. But we next wondered, how early in disease does this occur? And so this is where we turned our sights to our individuals at risk, or our IAR cohort. So again, these individuals to date would have no clinical signs or symptoms of RA, but do have an increased risk of developing the disease. And really what was so striking here was that we're seeing that this hypermetabolic phenotype actually precedes clinical manifestations, and we see this stepwise increase from healthy control to individuals at risk to RA in our inflammatory panel. But actually what was even, so again, these monocytes are hyper-inflammatory. But again, what was really interesting as well is that the metabolic capacity of these cells were extremely similar to RA. And again, this precedes clinical manifestations, so we get nearly indistinguishable metabolic profile between our individuals at risk and our RA monocytes, and also we get quite similar levels of key glycolytic enzymes. And so the final kind of investigation in our study was, we were wondering what happened at the site of inflammation, so the synovial tissue. And again, we can see here this enrichment of this monocytic pathway genes in our individuals at risk and in RA in comparison to the healthy synovium.
How do you interpret your findings?
I suppose really kind of what we've shown here is that these circulating monocytes are primed for inflammation, they're primed for hypermetabolic mechanisms, and that this phenomenon appears to precede clinical manifestations. And to our knowledge, this is the first study to date to have investigated the role of peripheral blood monocytes in these individuals at risk. And I suppose studying these individuals may provide important clues or important insight into the evolution of the RA as a disease. I mean, as we kind of had up earlier, we've got this stratification of patients across the evolution of their disease. And really, if we can study these patients early, perhaps we can identify those who may go on to develop an RA and those who may not. And also maybe those who will respond to treatment and those who may not, which I know Ursula will elaborate on in a minute. But kind of the last thing I'll say about this is, this study also fits into the whole knowledge that perhaps monocytes are capable of building immunological memory, and this may be via mechanisms such as epigenetic imprinting, which is interesting in the context of RA, given the huge role that an environment plays in this disease, as well as genetic component. So this is something that we're looking to develop further in further research outputs for our group.
And pulling back and looking at this overall, what are the wider implications of your findings?
So I was going to finish off on that. So basically, we started off this podcast talking about those patients there with chronic rheumatoid arthritis under number 3. And basically, when we were treating patients at that stage, you're talking within 5 years, patients had, functional disability, and within 10 years, the majority of rheumatoid patients had given up work because of this functional disability. So we've come a long way over the last 20 years, and we've got some great targets now that target individual proteins or target individual cells. But still, I kind of divide this into 3 groups. With rheumatoid arthritis patients at the moment, what we have is a third of patients respond great to treatment. A third of patients have suboptimal responses with side effects, and a third of patients don't respond at all. Now, if we treat them early enough, we get better percentage differentiation between all those 3. But clearly we have suboptimal responses in some patients, and we have no patients responding at all. And the other aspect of what's happening at the moment is that while we have all these great therapies, what happens with patients is they go into a clinic, they get a therapy, they might fail that therapy, then they get the second therapy, they might fail that therapy. And by the time they get to the third or fourth therapy, they have developed destruction in their joints, and it's irreversible. So what we want to do is to be able to give patients the right treatment on the day they arrive into the clinic at the very beginning, because we know the earlier we treat patients, the less chance they have of getting irreversible damage. So this, I suppose, study is allowing us, so the signature, we know the macrophage, which sits in the synovium, just as context, it's the only cell type that has shown as a biomarker in the tissue response to treatment, but we can't biopsy patients in a clinic. It's just people don't do it. So what this study has shown us that the signature that we're finding in the blood, which we could do in a clinic, seems to be reflective of those macrophages in the tissue. So what we're hoping is that if we expand this study into larger cohorts of rheumatoid patients, that it might help us to figure out what patients will respond to treatment or not, and a particular treatment. The second is that we're going to be monitoring the signature in those patients at risk, and that the minute they start to show signs of rheumatoid arthritis, that we can treat them early and again stop that irreversible damage. Some studies are actually treating patients even before they get, well, individuals before they get rheumatoid arthritis. And I suppose the final implication of the study is that for that third of patients that don't respond to any current therapies at the moment, we're suggesting possibly that this metabolic switch in the cells, if we target that metabolic switch, can we turn off the monocyte and then turn off the inflammation? So they're the three aspects I think that are really important. But the key message is that we want to find new therapeutic targets for patients that don't respond. And the earlier we can treat patients, the better their responses are, and we might achieve remission in more patients.